Hello, everybody, and thank you again for joining us for another one of our MAG seminars. Today we have the very lovely Emma Gambrell-Ball, who is an expert midwife and registered nurse. Emma has many years in the hospital setting, working both as a registered nurse and also specifically in midwifery, and she has experience training in midwifery as well. This is a very interesting topic today and something that is emerging more and more in the personal injury space in terms of the management of births. It's becoming more and more important too now with the shortage of obstetricians in rural and remote areas and generally, and with moves to changing the care models for women throughout their pregnancy. So without further ado, I will hand over to the very lovely Emma. If you are as impressed with her as we are, please know that Emma writes a really fabulous report, absolutely outstanding report. So if you need to have your matters assessed, please come forward and ask to engage with Emma. Thank you, everyone, and over to you, Emma.
Thanks, Michelle, and thanks for inviting me to join in with the MAG Connect Forum. It's a real pleasure working with MAG. And prior to my tooth extraction, of which I'm sorry I'm not on camera today, I really look forward to discussing this topic of medical negligence in midwifery. So this time, there's just a picture. So a little bit about me. As a child, I always wanted to be a midwife. Well, midwife or a fashion designer. All of my Barbies were made to look pregnant with a homemade tissue ball up their dresses, and my mum still remembers listening to me play concerningly, wondering what I was doing with the doll's house, because basically I'd turned Barbie's palace into a maternity hospital. So I've been busy delivering these babies and helping women in labour from the age of 7. After sixth form, I went to the University of Brighton in the UK, and there I studied nursing for 3 years. But in the back of my mind, I did always want to be a midwife. I just wanted to have a plan B in case Barbie Palace wasn't quite the reality. So I then worked in head and neck surgery and consolidated my general training, and following this placement went on to work in another hospital in gynecology and infertility. I then commenced my midwifery training again under the University of Brighton, and have since worked in hospitals, clinics, community, attending home births, water births, specialist midwifery and obstetric clinics. And part of the criteria to completing training in the UK is managing 40 individual deliveries. So that was a pretty intense course. We had a chance to do a sabbatical placement during this time, and whilst Africa and India were an option, I chose to work with a professor of midwifery in Rochester, New York, so that I combined it with a holiday in New York City at the end. Some parts of the USA at the time, midwifery and the practice of it was actually illegal, so she was a pretty pioneering woman that I spent time with. And years later, she actually came over and saw my own practice in the UK and worked with me on a few shifts. So this experience really opened my eyes to the flexibility midwife has to offer and use as a skill anywhere in the world to really help women deliver safely and with compassion, regardless of language, because I really believe midwifery is a language of its own, and I thoroughly enjoy using these skills following qualifying. So I bought a house in the UK, purchased a little sports car to zip around the community with my delivery pack in the boot, which was barely big enough to contain my delivery pack, but I wanted to incorporate travel into my professional role. So one night shift on a busy NHS delivery suite, I saw an advert to become a midwife in Hong Kong, and so I applied. The entry process needing to gain a place on the Hong Kong Midwives Register Council was grueling, to say the least. But my time in Hong Kong, which was nearly 2 years, was really culturally interesting. Understanding the importance of feng shui dates, superstitions, the ability to travel around Asia on my weeks off. So what was supposed to be a 12-month placement and a career break from the NHS ended up being nearly 2 years in Hong Kong. And from there, my life took a personal turn, and rather than go back to the UK, I came on to Australia. My initial plan at that point was to work in public healthcare. However, Ramsay Healthcare approached me and offered full relocation skilled migrants visa if I stayed with them for 2 years. Had a discussion with them after future plans, and 2 years later, and they offered me to part fund a master's in midwifery, of which I undertook at UTS. And since then, I've stayed with Ramsay Healthcare. I've worked on delivery suite, postnatal care, and offering antenatal care. I've been a clinical midwifery specialist of labour ward prior to having my 2 little ones, and ended up doing antenatal education on return from maternity leave, as well as continuing clinical practice on labour ward. So this whole time I've been practicing midwifery since then. It's often out of hours, on weekends, and frequently in charge of the shift. And having completed my last third of my master's with a 6-month-old baby and returning to work, I've managed to fine-tune these skills to now balance academic and practical work. So I decided to become an expert midwife, as it was a natural progression after 20 years of practicing as a midwife and 23 as a nurse, and I thoroughly enjoy this balance. So currently, my work is, as well as being clinical and using skills to write my expert reports, I also work as a practitioner member for the Nursing and Midwife Council New South Wales. I sit on various hearings concerning nursing and midwifery practice. I've also a wide range of skills drawn from these individual roles that umbrella the midwifery profession. So my background was I wanted to shed some light on a critical and often misunderstood aspect of the legal world, so the role of an expert midwife in the courts. Experts make an invaluable contribution to the judicial system in cases that intersect within the realms of childbirth and maternity care. Legal matters often intersect with various areas of expertise, and medical legal cases involving childbirth and maternal care are no exception to this. And when such cases arise, I find it essential to have a professional who can bridge the gap between the intricate nuances of midwifery and the complexities of the legal system. So expert midwives in this context serve as vital liaisons, providing specialist knowledge and experience to help the court and lawyers understand and explain the situation in clear English. Therefore, I hope that we help the court make well-informed decisions. So today I'm going to talk you through the multifaceted role of experts in the courtroom and highlight the necessary qualifications, the types of cases in which we're involved, and the impact an expert midwife has on legal proceedings. I am remaining in clinical practice and have continued to, as I said, for 23 years as a nurse and 21 for a midwife. So yeah, I'm old. So for a medical negligence in midwifery, for a mistake to be deemed negligent, it must be shown that the standard of care provided fell below what is expected of a medical professional, and in this instance, a midwife. It's important, however, to remember that not all birth injuries are the result of neglect. And there are a number of occasions when a mother could receive exceptional care and yet damage still occurred. However, the result of medical negligence can have lifelong effects for the mother, the child, and her family as a whole. A delay in intervening with difficult births may cause hypoxia, such as brain damage, cerebral palsy. The health of the mother and child could be placed at risks with an infection such as group B streptococcus, which can cause an infection to the mother's urinary tract, placenta, womb, amniotic fluid, and preterm labour. Inadequate monitoring such as fetal growth antenatally, being macrosomia too large or IUGR too small, both require specific acknowledgement antenatally, during labour and postnatally. And if risk factors aren't identified when deciding upon the type of monitoring required in labour, problems can arise. The midwife is also responsible for identifying potential antenatal or intrapartum issues and referring to an obstetrician in an appropriate and timely manner. So, for instance, a successful medical claim for midwifery could help towards long-term care of the child, could pay for appropriate treatment and therapy if required, and could also cover other costs the parent has endured as a result of their child being injured by negligent care. Clearly, the above aims to maximise the quality of life the child should have, albeit if it was very different to what was imagined. Midwifery negligence and birth trauma claims can be difficult to prove, especially if the mother or baby's care is ongoing and the long-term injuries may well be unknown. So the choice of appropriate expert is highly relevant and would ensure your client's notes and relevant enclosures contained within the letter of instruction are forensically examined to identify injury and malpractice. When examining the standards of clinical care given, and as an expert midwife, I'm fully aware as to the profound and devastating impact an adverse birth outcome has on both parents, the wider family, community, and of course, the child themselves. As an expert midwife, I'm also highly cognizant as to the distress, pain, suffering, loss of control, economic loss, isolation, mental health effects felt by a woman who has found herself at the centre of a claim. An example, the potential long and protracted implications of a debilitating third and fourth degree tear. The distress in many cases of negligence in midwifery felt is often long-term and very profound, and the impact of a pregnancy and birth such as the above can be totally devastating. This devastation, if further compounded when the incident occurred due to negligence and was therefore avoidable, is only further impacted. So why engage an expert midwife? The choice of an expert midwife over an expert doctor in certain legal cases can be a matter of specialisation and relevance to the specific issues at hand. A few reasons why an expert midwife might be preferred could be due to her specialist knowledge. Midwives are trained professionals. They specialise knowledge with experience in pregnancy, childbirth, and postpartum care. They're often well versed in the standard practices and protocols related to normal childbirth, which can be crucial in cases involving childbirth-related issues. Midwives primarily deal with low-risk normal pregnancies and births. They have extensive experience in providing care during uncomplicated birth, making them more suitable for cases involving such situations. However, midwives are also involved in high-risk cases working alongside obstetricians. Midwives often take a more holistic approach to maternal care, considering not just the medical aspects, but also the emotional and psychological well-being of the mother. And this perspective can be valuable in legal cases where the broader context of care is essential. Within the public health system, midwives often provide continuity of care throughout the pregnancy, labour, and post-delivery, which allows them to have a comprehensive understanding of the case and its intricacies. And also, midwives can help avoid bias. In cases where a doctor's actions or decisions are in question, having a midwife as an expert witness can help provide an impartial perspective and mitigate potential bias, as midwives typically work outside the hospital setting in question and may not have affiliations with medical institutions involved in the case. So it's important to note that the choice between an expert midwife and an expert doctor depends on the specific circumstances of this legal case. And in some situations, it may be more appropriate to involve both experts to provide a comprehensive view of the matter. Ultimately, the decision should be based on the unique requirements of the case and the expertise needed to address them effectively. So, type of cases to date. I've written up a number of cases where midwives have been involved in medical negligence, and the range is fairly wide, where our specialised knowledge and expertise in childbirth and maternal care are pertinent. Some of the common types of cases in which midwives may be called upon to provide their insight and testimony into include allegations of negligence or substandard care provided during pregnancy, childbirth, and post-delivery. Expert midwives can help evaluate whether the care provided met the standard of care and whether any deviation from that standard resulted in harm. Expert midwives can be involved in cases related to traumatic birth experiences, which may include injuries to the mother or baby during labour and delivery, as well as the emotional impact of such experiences. When a newborn sustains injury during birth, expert midwives can assist in determining whether the injuries were preventable, the result of medical negligence, or due to other factors. Expert midwives may be consulted in cases relating to licensing and regulatory aspects of midwifery practice or maternity care facilities. In cases where the standard of care provided by a midwife is called into question, an expert midwife can assess whether the care met established standards and whether deviations from these standards contributed to adverse outcomes. So cases may involve disputes over whether a pregnant woman was adequately informed about the risks and benefits of certain medical procedures or interventions during childbirth, and whether her consent was obtained appropriately. Expert midwives can be involved in cases concerning maternal health issues, such as complications arising from pregnancy, pre-existing health conditions, or issues related to postpartum care. It's important to note that the specific involvement of expert midwives in legal cases depends on the unique circumstances and the needs of each case. Our expertise helps ensure the court receives accurate and informed insight into the maternal care and childbirth aspects of the case, contributing to the fair and just resolution of legal matters within this domain. So how I work with MAG. I offer a free preliminary opinion, teleconference with the lawyers. If appropriate, letter of instruction and enclosures would be forwarded. I then submit a formal report with a turnaround time of 3 to 4 weeks. But urgent reports can usually be attended to if required. And I'm happy to provide supplementary reports on request as well. Any questions?
Well, firstly, before we do that, I just wanted to say thank you very much, Emma Gambrell-Ball. That was really interesting and very clear structure of the value of an expert midwife in these matters. So anyone, do you have a question that you would like to ask of Emma? You can unmute yourself to do that. Okay, Emma, I've got, oh, someone, Gwenda?
Oh, right. Okay. Can you hear me okay?
Yes.
Yes.
All right. I'm just wondering, Emma was saying that the effects of a bad experience can be long-term and quite damaging. Is it appropriate then, do you think, to have a limit of 3 years for a medical negligence claim in those circumstances?
Hi, Gwenda. I don't think you can put long-term damage into a time limit. Often when an incident occurs, there's initial shock, and obviously mental health issues can come out over a protracted period of time, not necessarily the same from one person to the next. But I do understand that it's difficult to realise as lawyers when to pitch that time, when's their worst mental health on display. But I think it is really an individualised thing, of which I would work closely with a perinatal mental health specialist to come through, because it can be obvious physically that someone is suffering trauma. As to the long-term effects of that, it's something that would be out of my expertise. So I would like to say that I think to put any time limit on trauma, depending on the person's recovery and the nature of the trauma and how it's resolved to date, is a difficult one. I think living with a child long-term or living with physical complaints that affect your daily life for a number of years, not just months, would have a continual mental health effect on the woman, which is why I'd hold back from saying just 3 years.
Yeah, good question. Good question. I have a question for you, Emma, from someone who was unable to attend today, and they wanted to know what were your views on the thing called a doula that we all hear about in the magazines and you know, the sort of articles, the wellbeing articles now, the doula. What is the difference between a doula and a midwife? And what is, in your opinion, the value of a doula and the risks of a doula?
So a doula is untrained as far as it comes to the hospital system. They're not nurses, they're not midwives, and there's no specific training a doula has to undergo to market themselves as a doula. I suppose I'd see a doula's role as more of a big sister role in a client who feels she needs extra support, which sadly is the case a woman may feel due to the fact of staffing limitations, the limitations of midwives being available. But ultimately, the midwife should be able to provide you with the comfort and support a doula does, particularly in a continuity of care model. And obviously not all hospitals have that, where the midwife knows the woman from the beginning to the end of pregnancy and carries through the labour. And so I think those gaps lead for women to consider using a doula. They're not cheap. Their help within the hospital system needs to purely be on focus of working with the midwife and her partner to ensure that the woman's labour is smooth and hopefully all that she wished it to be. But it's not to be in place of a partner being educated to support their partner throughout the process of their child. So I do see a area of need for doulas, sadly, because of a lack of care within the community on discharge for issues such as breastfeeding. I think that can be really helpful for women to have someone they can call upon. And I know doulas do often work 24 hours a day so that they can be contacted by their client to come and help with a feed. And that's sadly something, if women have gone home soon from hospital, not being set up, being able to feed appropriately before they leave, it can be a frightening time at 11 o'clock at night when your baby won't feed. You've got telephone advice on the end of the phone, but to have someone actually sit with you and go through it, I can see a benefit too. I just have always had the thought, having worked with doulas in the past, it's kind of an all care, no responsibility. And it's a role that I like to provide women that I care for, as many midwives do. It's the enabling, the speaking up for, the empowering, the physical care of women in labour is something that is within the midwife's role to perform.
Right.
So there is value, but there's a big difference. Midwives are not doulas and doulas are not midwives.
Okay. And following on from that then is the next question, and that would be, particularly I'm thinking in the context of a home birth, where a woman has specifically chosen not to have the medical intervention that comes with a hospital setting. How does a good midwife make that decision that this is going pear-shaped and we need to go to hospital?
Well, it would only be right for a woman who is wanting to have a home birth to be low risk, and that is her pregnancy is low risk. She's encountered no problems throughout the pregnancy. There is some research to suggest that it should be women that have had a previous vaginal delivery then having home births. It needs to be with an experienced midwife as well. And there needs to be an unwritten contract and agreement that should the midwife not be happy with the progress, with the heart rate, it's not a turning your back on the hospital. It's the fact we'd like to start off at home, hopefully delivering at home. But if things were to change, then the midwife will be wanting help from a wider group of professionals. And that's what the woman needs to understand when she signs up for a home birth. It doesn't guarantee you a home birth because the delivery pack's arrived in your lounge. Obviously, that's everyone's aim. But if things do become abnormal, they need to be acted on, not have a blind eye turn to them. You can't turn your head on things in order to keep someone at home when clearly labour isn't progressing as normal. And that is negligent not to do it.
Okay. Now, following on from that, you in your role have been active in mentoring, training, and indeed teaching young midwives and nurses who want to become midwives in the role and supervising new midwives in their practice. My question will be, how, as a more experienced midwife, do you help them to know when they need to speak up if they feel that perhaps the obstetrician is missing out on cues from the woman or is making the decisions that are perhaps contrary to what the woman giving birth is saying?
Sure. So, Michelle, you mean encouraging a junior midwife to speak up for the woman's wishes?
Yes.
I think a big part of that is leading by example throughout their training, that hopefully having students follow us as senior midwives, they see that we work closely with the women. The doctors aren't there for a majority of the time. And even though in private healthcare, they've had a lot of appointments with the doctor, they haven't seen them regularly and over a number of hours that we have in labour. So it's important to have that conversation with the women, and I certainly do. If the woman's very specific, for example, if she's had she's agreed to an induction of labour, they've broken the waters, they've done an ARM, but she doesn't wish to have the syntocinon infusion put up straight away. She wants to mobilise, try and establish labour naturally. I would have encouraged her, and in the presence of a junior midwife training, to come up with the risks and benefits to that. If babe's fine, there's no reason why she can't mobilise before the next stage if contractions don't start. So it's making the junior midwives realise that their obligation is to care for the woman safely and also to advocate for them. And sometimes that can be difficult to have conversations with certain doctors. That'd be the same for any nurse and midwife. But it's to give them the confidence and to fall back on senior midwives to back them so that they in turn end up developing a career with the women's wishes in the forefront of their mind, as well as safety and practice from their own maternity care.
Lovely, lovely. Does anyone else have any questions I would like to ask of Emma Gambrell-Ball? I have one last question.
Yes.
Terrific. Okay. And that is in the event of a precipitous delivery where the baby is born either stillborn or with significant low APGAR score or some kind of scary presentation. What becomes the role of the midwife when that happens?
So precipitate delivery in hospital. So you mean by precipitate?
So in the hospital setting, yep.
Sure. So the delivery happens very quickly, quicker than would be expected. And then the baby ends up with low APGARs. So there's a few issues that can occur with precipitate delivery for the baby and mum. Obviously, it depends on why the delivery was precipitate. Did she just spontaneously deliver quickly? Or maybe there could be something like an antepartum hemorrhage, so an APH, or intrapartum hemorrhage in labour. So the placenta is starting to come away from the uterine wall and the body naturally speeds up the process by expelling the baby quickly. The role of the midwife at that point would be to, if the baby's got low APGARs, to initially assess the baby. And depending on what the APGAR score is at that point, to then call in further assistance, either by MET call senior midwife, if a paediatrician's on site, your special care nurses around, because obviously precipitate delivery is unanticipated speed of it. So once babe's cared for, the midwife is also in charge of looking after mum and making sure she can often go into shock after such a quick delivery, and also maybe cause vaginal damage that would need to be sutured and assessed, and also her risk of postpartum hemorrhage. So the midwife needs to be over 2 areas, but having allocated, once babe's delivered, babe to specialists and mum to be cared for by that midwife, hopefully keeping the babe in the same room as mum so mum can see what's going on.
Yeah. So it's really about the midwife not only being skilled in all of those interpersonal skills, working with the mother and the partner, but also understanding the critical pathways. So whatever the medical or clinical presentation that occurs with the baby or the mother, the midwife's got to be right onto it and know what pathway she needs to move down to manage that presentation, right?
Absolutely. And the quicker you start effective resus, if that's what's required, the less likely of a need for intervention. So the quicker you can get onto that, definitely, Michelle.
Lovely. And sorry, one last one. I did say the last one was the last one.
Oh.
So midwives don't use forceps, correct?
Correct.
Don't use suction, ventouse or kiwi unless they're in a remote or regional setting and it's an emergency?
Correct. I've never seen a midwife use of kiwi ventouse before, no, but I do know that it can occur.
But can do an episiotomy?
Yes, definitely. Great. It's very infrequent. Midwives would have to. Often you're looking at episiotomies are mainly used by obstetricians when deciding about an instrumental delivery, because that aligns with the research of a perineal tear is likely to be less significant with an episiotomy than with certain instruments that are used. So as midwives, we are trained in suturing and performing an episiotomy. And really, we would only need to do that should there be significant fetal distress to expedite the delivery, or if you can see what's called a buttonhole tear occurring. So it looks like a 3rd-degree tear might be happening. Part of the perineum's tearing that shouldn't. So it just widens that diameter. There is a case for consideration for episiotomy as well when shoulder dystocia is diagnosed, when the baby's shoulders are stuck coming out. But again, it's a bony issue and that's a soft tissue problem. So it's just a consideration.
Wow. Look, thank you so much for what has been a very interesting and informative talk, and for making the time to spend with us, Emma. We're very, very grateful for that.
Well, Michelle, thanks for inviting me to talk on a subject that I could talk about all day and some of the day with a dry socket. But please don't hesitate to contact me via MAG, because I'd be very helpful to see if I can assist any of you in your cases.
Lovely. Thank you, everybody, for attending this session. The recording for the session and the slides will be made available to you within about a day. And of course, you can always view our sessions through the MAG Connect platform by clicking on the menu item Seminars, or by going to Medico-Legal Assessment Group YouTube, and all of our sessions are there. Thank you so much, and we look forward to seeing you at the next one. Have a great rest of the day, everybody.